Hi, I'm Dr. Peterson with Regions EMS. Emergency medical care has changed a lot over the past few decades. From the initial mobile cardiac intensive care units of Ireland to Seattle's Medic One program and the development of the paramedic profession in the United States, EMS has always had a heavy focus on the management of cardiac arrest and other cardiac emergencies. Pre-hospital providers have also pioneered the research into new medical devices such as the rescue pod, the rescue pump, the Lucas mechanical CPR device, and other game-changing advances in cardiac care. Cardiac emergencies still remain a significant focus for EMS, as these emergencies are very time-sensitive. The difference between life and death is often a matter of minutes or sometimes even seconds. The American Heart Association's chain of survival recognizes emergency medical services as a key component in the spectrum of care for cardiac patients. We would like to always be challenging ourselves to become better, smarter, and more efficient at managing these patients. As EMS providers, you truly are the experts in cardiac arrest management, and we should be especially proud of the work we have done in the Twin Cities area to further improve the care provided to patients with cardiac emergencies. And on that note, let's look at the new cardiac guidelines, starting with Guideline 11, Adult Cardiac Arrest. Instead of reviewing the ACLS algorithm, I will focus instead on the changes with the 2014 guidelines. Cardiac arrest incidents can be very chaotic. There are typically numerous medical providers and bystanders present, and emotions and adrenaline levels run high. In these situations, it is important to have a systematic approach to ensure that several key treatments are considered. Some agencies refer to this as a pit crew model, similar to a NASCAR pit crew, where each team member has a specific set of duties that are performed the same way each time. Many agencies manage cardiac arrests with a mini incident command structure. The incident commander maintains scene security, staging of resources, and the logistics of patient movement from the scene to the ambulance when ready. A separate ALS team leader or code commander can then focus on the medical aspects of the resuscitation and, if possible, should remain hands-off from the patient. If enough personnel are available, a third provider, either ALS or BLS, can be assigned as the perfusion supervisor to ensure that high-quality, continuous chest compressions are being performed, pauses are limited to 5 seconds during pulse checks, the rescue pod ITD device is in place, an end-tidal CO2 detector is present, and ventilations are occurring at an appropriate rate. This person does not concern themselves with medications, the cardiac rhythm, or other considerations. The remaining personnel are then assigned to provide ventilations and airway management, chest compressions if needed, equipment and monitoring devices, vascular access, and medication administration. There should be a clear resuscitation leader, and the checklist on the back of Guideline 11 should be utilized to ensure that all of the critical interventions are performed. Let's go back to the front of the guideline. Unless the arrest occurs in your presence, the first priority for an adult should be to initiate chest compressions. Rhythm analysis and defibrillation should be the next priority, followed by ventilations and the application of a mechanical CPR device and an ITD if there is no evidence of trauma. Airway management can typically wait in adult patients until the other priorities have been addressed, and if possible, chest compression should not be stopped during airway device placement. At this point, ALS providers should follow the appropriate cardiac arrest guideline for shockable or non-shockable rhythms. For BLS responders, you should always provide an initial round of compressions and AED analysis on scene. If a mechanical CPR device is available, begin preparations to transport the patient to the closest hospital unless an ALS responder is en route. If a mechanical CPR device is not available, you should provide 2 more rounds of compressions and AED analysis on scene before transport, as we know that standard CPR is not very effective during transport. Early MRCC notification is important in order to mobilize resources at the receiving hospital. The corresponding Pediatric Cardiac Arrest Guideline number 41 is very similar. The main difference with pediatric patients is that cardiac arrests are much more likely to be due to respiratory issues, so efforts should be focused on airway management and ventilations. it would always be appropriate to rapidly transport a pediatric arrest to the closest appropriate facility. MRCC can provide guidance on the appropriate destination if needed. Let's look at Guideline 12, the Adult VFib-VTAC Guideline. The key management point here is that the team leader should make sure that pulse and rhythm checks are being done every 2 minutes, compressions are restarted immediately after the pulse check and continued through the charge and shock phase, medications are anticipated, drawn up, and administered appropriately. The right side of the guideline highlights 2 special situations: polymorphic VTAC or torsades, which should be treated with magnesium sulfate after defibrillation, and hyperkalemia. This should be suspected in any dialysis patient and should be treated with calcium chloride and sodium bicarbonate early in the resuscitation process. If your patient remains in a shockable rhythm after 4 CPR cycles, or at any point is showing evidence of neurologic function, you should consider rapid transport to a cath lab capable facility. There are no significant differences in the management of pediatric shockable arrests. However, transport should be initiated as soon as possible for a shockable pediatric arrest. Contact medical control for advice if there are any questions. All right, on to Guideline 13, the Adult Asystole and PEA Guideline. For ALS providers, these patients generally do not do well and should not be transported unless there is evidence of neurologic function or unusual circumstances are present. The team leader should consider all reversible causes of the arrest using the H's and T's checklist and address these early if possible. PEA rhythms with normal or tachycardic rates should also be considered for transport, as this would suggest a non-cardiac cause for the arrest. The key management point, again, is continuous chest compressions with minimal interruptions. For pediatric non-shockable arrests, airway management would be the first priority, and again, early transport should be considered. So what happens when you get a pulse back? Let's look at Guideline 14, the Adult Post-Resuscitation Guideline. Pediatric post-resuscitation management is identical to adults. The heart is typically very irritable in the immediate post-arrest period, so be prepared to restart compressions if indicated. One provider should be assigned to continuously monitor the cardiac rhythm and pulse for any changes. Another provider should begin to coordinate transport logistics, if not already done, and a complete set of vitals with a 12-lead EKG should be obtained. The back of Guideline 14 has a post-ROSC checklist which should be reviewed for critical treatment considerations. The rescue pod should be removed, cooling should be initiated, and the patient should be transported to a cardiac receiving hospital. If your patient remains hypotensive after 2 consecutive blood pressure checks, consider starting a pressor agent such as dopamine or epinephrine to treat cardiogenic shock. Drip rates are given in the guideline and should be titrated to a palpable radial pulse or a systolic pressure of 90. Okay, let's shift gears and look at Guideline 15, the Adult Narrow Complex Tachycardia Guideline. If at any point your patient becomes unstable, which includes chest pain, you should perform synchronized cardioversion at 100 to 150 joules without delay. If possible, a 12-lead EKG should be obtained, but this should not delay cardioversion for an unstable patient. If the patient is stable, you should first determine if the rhythm is regular or irregular. An irregular tachycardia in an adult is atrial fibrillation until proven otherwise, and if no significant symptoms are present, supportive care is all that's appropriate. Regular narrow complex tachycardias are typically either SVT or sinus tachycardia. Vagal maneuvers and adenosine can be considered, and we are now recommending a standard adenosine dose of just 12 milligrams as a rapid push through the closest IV port to the patient. We have eliminated the 6 milligram dose for simplicity's sake. Anytime the rhythm changes, a 12-lead EKG should be obtained, and medical control is always available for treatment advice. Guideline 16, wide complex tachycardia, is very similar. Unstable patients should be cardioverted immediately, and if the monitor is not able to synchronize with the QRS complex, you should consider defibrillation. If the patient is stable, irregular rhythms are most likely due to atrial fibrillation with a bundle branch block, and no special treatment would be indicated in the pre-hospital environment. Regular wide complex rhythms are either SVT with a bundle branch block or, more commonly, VTAC with a pulse. Either way, amiodarone would be the appropriate antiarrhythmic medication to administer. If you suspect torsades, you should immediately defibrillate and then administer 2 grams of magnesium sulfate. Pediatric patients have a different set of considerations for tachycardia, as shown in Guideline 45. Cardioversion is still the treatment of choice if the patient is unstable. Otherwise, wide complex or irregular tachycardias in kids should be treated supportively or in consultation with medical control. Wolff-Parkinson-White syndrome would be the main concern here, and adenosine could significantly worsen this condition if it's given. A regular narrow complex tachycardia in a pediatric patient would either be SVT or sinus tach and can be treated accordingly as shown in the guideline. Okay, let's look at Guideline 17, adult bradycardia. The key point here is that bradycardia should really only be treated if the patient is symptomatic. Pacer pads can be placed as a precaution if there is a concern for heart block. For symptomatic patients, the treatment options in order would be atropine, IV fluid boluses, transcutaneous pacing, which can also be considered first for severe cases, and pressor agents such as dopamine or epinephrine. Other things to consider would be a medication overdose such as beta blockers or calcium channel blockers, or an inferior MI, which should be treated accordingly. For pediatric patients with bradycardia, airway management should be a priority, and atropine would not typically be indicated. IV fluids would be the first priority, followed by epinephrine, and finally transcutaneous pacing. Okay, back to adults, Guideline 18, the STEMI guideline. This is very straightforward. The key treatments are aspirin, rapid transport, and early MRCC notification for cath lab activation. Nitroglycerin should be used with caution if an inferior or right-sided MI is suspected, as your patient would be very dependent on their preload for cardiac output. The rest of the treatment is supportive, with rapid transport to a cardiac receiving hospital. The final guideline we will review in this video is Guideline 19, the CHF and pulmonary edema guideline. Most of these patients are in some degree of respiratory distress, which is the main priority to address. Nitroglycerin can be used if the patient is not hypotensive, and CPAP can also be considered early if the respiratory distress is significant. IV fluids should be avoided unless the patient is significantly hypotensive. Now that was a lot of information to cover, but these are very important guidelines to be familiar with. As always, the staff here at Regions EMS is always available for any questions you might have about these guidelines.